I had an experience of listening to patients personally and their relatives in the course of 2 inquiries. The first inquiry, I met them in private. Not everyone agreed that I should have done that. But I had the experience of sitting in a room with a number of other people and listening at the rate of some 3 families a day for 3 weeks, telling me about their experiences, their appalling experiences in Stafford Hospital. And I've made no secret about the fact that it had a profound impact on me. Hearing some of the same stories and some new ones at the public inquiry had a similar effect on not only me, I think, but all those who sat there listening to them. And my report, as has been said, thumped on the desk. And immediately a discussion has started. In many ways an encouraging discussion, at least there is a discussion taking place. But sometimes in the world beyond rooms such as this, one might get the feeling that the patients are being forgotten in relation to what is it that we actually need to do to change the circumstances in which appalling care was given in at least one of our hospitals, and may, if we believe what we read and hear, be going on in others. So I'm afraid those of you who have heard me speak before in the last couple of weeks will find 1 or 2 familiar things, but I do, I'm afraid, want to read to you an account that was given to one of my inquiries about a 96-year-old patient, because I don't think what we've just heard is absolutely fascinating and very valuable, but we do need to know the stories. We got there about 10 o'clock, and I couldn't believe my eyes. The door was wide open. There were people walking past. Mum was in bed with the cot sides up, and she hadn't got a stitch of clothing on. I mean, she would have been horrified. She was completely naked, and if I said covered in feces, she was. It was everywhere. It was in her hair, her eyes, her nails, her hands, and on the cot side. So she'd obviously been trying to lift herself up and move about, because the bed was covered, and it was literally everywhere, and it was dried. It would have been there a long time. It wasn't new. In addition to those sort of stories, of course, I heard those from staff. And I think sometimes we forget the impact on staff of some of the things they've had to witness in this hospital. A doctor in A&E who turned out to be, he was a trainee doctor and became a brave whistleblower, said this: "The nurses were so under-resourced they were working extra hours. They were desperately moving from place to place to try to give adequate care to patients. If you're in that environment for long enough, what happens is you become immune to the sound of pain. You either become immune to the sound of pain or you walk away. You cannot feel people's pain. You cannot continue to want to do the best you possibly can. When the system says no to you, you can't do the best you can." Now, what is it that we can do? I could, of course, talk for days on what went wrong in Stafford, but what is it that we need to do now? Famously, I have made 290 recommendations, but I'm frequently asked, as I have already been today, what are the most important ones? What are the things that are really going to make a difference? And the answer is all of them will make a difference. In one respect, we wouldn't need any of them if everyone just changed the attitude today and we stopped talking about structures, reorganisations, new policies, and actually got on with a change of attitude, which is thinking about the impact of the patient, on the patient of everything we do. But just to set the scene, what I've said when I launched this report, and I'll just repeat to you again, in my view there are 5 principal themes behind the recommendations that I've made, and I think if we think about those themes, then the answers become clear. The first is a structure of clearly understood fundamental standards and measures of compliance, accepted and embraced by the public and healthcare professionals, with rigorous and clear means of enforcement. Secondly, we need openness, transparency and candour throughout the system. That means a common culture of serving and protecting patients and of rooting out poor practice so that it won't spread through the system. Thirdly, we need improved support for compassionate, caring and committed nursing. There are many compassionate, caring and committed nurses in the system. They need to be empowered to deliver the care that they so often are able to do. And those who aren't able to do so must either be trained to do so or asked to leave. We need accountability and regulation amongst those who don't have the benefits of that training. We need to make sure that healthcare support workers are fit for the very difficult job they're being asked to do. And within that, let me just say this, we need to value more than we do the compassion, caring that needs to go on, so that when it's provided, it is properly recognised. These are not easy jobs. We also need strong patient-centred healthcare leadership, and that requires more training, better selection, more support, and at the end of the day, accountability. And finally, we need accurate, useful and relevant information available to all who need it. And obviously you've been hearing something about that, I think, today. So those are the themes behind my recommendations. And just one thing, if I may, about my report. In case you've been reading the wrong newspapers, I would like to assure you I did write the report. And there may be many criticisms that can be made of the Department of Health, but writing my report is not one of them. But thank you very much.
So thank you very much for that, and perhaps I can voice appreciation on behalf of everyone here, maybe, for the very thorough and committed work you and your team did on mid-staffs, and clearly it was a huge effort. Can I just, before I turn to the panellists, can I just ask a couple of questions? Can I just press you a bit on the 290 recommendations, because clearly, as you know, the service is hammered at the moment in a number of ways. And really, to try and make sense of this would be helpful if there were some priorities that you felt that you could signal. I clearly hear you wanting to resist that by pointing up themes, but can you narrow it down at all as to what might be the immediate must-dos in the next year or so?
Well, I've said that there's a lot that can be done without actually waiting for the government to tell you, and it is you, I think, to actually get on and do it. And the first and foremost seems to be openness, transparency and candour. You don't actually need rules and regulations to get you to do that. We can start to be completely honest and open with patients who've been harmed today. We can set about with the professions producing information which gives us a balanced picture of the poor things that are going on as well as the good things. We can ban gagging clauses in trusts so that people aren't prevented from raising patient concerns. Everything that I have said should be encouraged by regulation, or everything that I've said that requires accountability can be done without those things. What I've said, however, seems to be unhappily the conclusion that we need some regulation, and we need some encouragement in relation to criminal sanctions, because otherwise these things won't work. And just on that point, if I may, it may come up later, I think it should be obvious to everyone now, even if it wasn't before, something that I said at virtually every seminar I had in the course of the inquiry, is there is an immense amount of anger out there amongst the public about the appalling care that has been inflicted on people in Stafford, but not only there, what's perceived to happen elsewhere. And I'm afraid we've got beyond the stage where we can sit in cosy rooms and reassure each other that things are getting better. The public require, and it's obvious they require, proper accountability. And the current system does not deliver proper accountability when things go wrong. And I'm afraid part of the reason for some of my more stringent recommendations is that is required. And frankly, I don't think we will regain full confidence and trust from the public until we have that sort of system in place.
Okay. We know here what a culture in the NHS looks like, of command and control, strong arm performance management targets, P45 targets as they were called. We know what it produces. Fear and grip can sometimes produce perverse effects. So I'm interested, if we want to encourage openness and transparency, about this criminal sanction idea, because on the one reading of that could be actually people will be driven to hide more if there's the threat of criminal sanction, particularly against fundamental standards. So you must have thought very carefully about that before you put pen to paper on that particular issue. Why did you conclude that that was absolutely necessary?
Well, there are 2 points. Firstly, I suggested a criminal sanction for willfully obstructing people not owning up, if you like, about things that have gone wrong.
Yes.
And at the moment, we had appalling stories at Stafford about the bullying of a nurse who was a whistleblower to such an extent that she left a trust. Now, that's not something that the management did, that's what her colleagues did. And it seems to me that that's utterly unacceptable, that something needs to be done about it. That's my proposal, I think, encourages openness, or at least prevents it being suppressed. With regard to the standards and any criminal sanction behind that, obviously it would be a last resort and only for the serious cases where harm or death is caused by a breach. But before you get to that, obviously we need a set of standards that's much clearer than what we currently have with the combination of the regulation and the 300 pages of Care Quality Commission outcomes and guidance. Because I don't think a nurse or a doctor or a patient would actually know on the ward at the moment whether the standard was being breached or not. So what I'm actually talking about is a criminal sanction in relation to death or serious harm caused by utterly unacceptable care. And what those utterly unacceptable things are need to be debated, both with the public, so it's owned by the public, and also by the profession. So I'm not suggesting just imposing a different form of criminal sanction on the current system as we know it now. I'm talking about a much clearer standard that we actually understand, we the public, that is.
The police with the Stephen Lawrence inquiry had what was described as a Macpherson moment, where it was a kind of game changer. The label of institutional racism stuck, and they are still examining themselves. We haven't had such a label. Maybe institutional neglect might be it in this case, perhaps. But given you're doing the circuits now in the NHS, do you sense that the NHS gets this? Do you think it is such a defining moment for them, or is it too early to tell?
Well, I think it's a little early, excuse me, a little early to tell. I'm certainly hearing the right language from lots of people in lots of places, and I think actually the interest shown at the audiences that turn up, and it's not because I'm an entertaining speaker, it's because people think that what we're talking about is really very important. And so that is so at the moment. But of course, that feeling has to be translated into action, or otherwise it will all fade away and it will disappear into chip paper sooner or later. And we can't afford to have that happen, because if you allow that to happen, there will be further disasters. And the next one, or the one after that, could end, frankly, in something more apocalyptic for the health service than we have at the moment.
Yes, just on that, there are references in your report to the fact that other people from other hospitals were referring things into you.
And still are now.
And still are. I just wanted to ask, what's being done about that? Did you then refer them on somewhere else, or? Well,
obviously, I feel helpless. I read very distressing correspondence. I am doing my best to answer it in terms of some degree of sympathy. I can't look into these cases. I have no power to do that. So I have to refer them to, often I will send the letter to the Chief Executive of the Trust, but I will also send them to the Care Quality Commission, the Department of Health, whoever else I think might be able to do something about it. But I'm sure everyone, whoever raises their head in public in this field, will be getting such correspondence. And I just feel there are a lot of people out there that have not had their complaints looked at properly. Yes. It's difficult to say. Obviously, you only hear one side of the story, but that's my feeling.
Okay, thank you. And just final question. Are you going to stay on the case now, as it were, into the foreseeable future? You've obviously given some recommendations that every year there should be at least some kind of analysis report of progress. Are you going to personally stay on the case, or?
Well, my personal plans are to return to my day job. I was asked to do this. I am a practicing barrister with a completely empty diary as a result of doing 3 years work on this. But that's the hazard of being a Queen's Counsel, dealing with big issues. I will obviously retain a personal interest, but my authority to speak as anything other than a member of the public will stop the day that the inquiry shop closes, which is any day now.
Thank you. Thanks. So let's just move on now to Anne-Marie. So nursing is taking an utter hammering, isn't it? I mean, almost everyone you talk to has their own story about nursing and the failures And clearly, Francis did not pull his punches when it came to nursing, and neither the Select Committee earlier on this week, I think, talked about the Nursing and Midwifery Council and the failure and so on of regulation. What has gone wrong here, and what does it take to fix what is wrong with nursing?
Well, I think the first issue is to have a proper diagnosis of what the problem actually is in the first instance. And there's clearly multiple diagnoses out there. One is that it's all the fault of education, for example. So as someone who works in the university, and indeed was the head of the foundational school of nursing and midwifery in this country, I obviously recoil from that criticism. I don't actually think that the problem lies with education per se, insofar as we actually have a relatively low concentration of graduates in our workforce. In a recent survey we undertook across Europe in a major European study, RN forecast, England has only 28% of its graduates, nurses who are graduates, and that's at the lowest end compared to many of its peer European countries. So actually we are falling behind those countries. We're not in the vanguard or leading the fray. So that's the first point I'd like to make about education. I think really the issues around staffing, which I think was clearly in the case of the Francis inquiry at mid-staffs appalling, and those staffing levels had become sacrificed to the overriding economic and financial imperatives of the trust as it moved into its objective of pursuing foundation trust status. So I think it took its eye off the ball and allowed nursing staffing levels to drop so dramatically that they were in fact, to say suboptimal is an understatement, putting it mildly. So staffing, as we know from lots of research on the links between staffing levels and patient mortality, is absolutely crucial, and the staffing levels there were totally and utterly inadequate. The other issue that's really important is, of course, leadership. I think, leaders have to lead by example. People are influenced by what people do, not what they say they do. So stiffening the sinews at every single level in the system, and particularly with respect to ward leadership, is absolutely crucial. The role of the ward manager, the ward sister, charge nurse is absolutely essential and key to driving up and setting those standards. We're social beings, and we respond to what we see around our practice environment. So my diagnosis of what happened at mid-staffs is there was serial inputs which really produced a kind of cascading collapse in standards at the ward level that then created all manner of impacts that ricocheted throughout the whole system. And when you have inadequate staffing, that is one symptom, but other symptoms of a system that's in real trouble. But the other symptom is that nurses then have the dilemma of having to make decisions about the care that they prioritise and the care that they do not do and they leave undone. We also have research from that same study that demonstrates that the things that nurses prioritise when they don't have time to do all the things they see as actually part of their role, they prioritise medication, particularly analgesia, and responding to the immediate human cry for help for pain relief. They respond to the treatment decisions par excellence, so the procedures that enable patients to move smoothly through the service, so that, in fact, that the pathway out of the hospital is relatively intact. The things that go by the wayside are the comfort measures, so talking to patients, educating them and their families about their care, helping to plan for discharge, and indeed all of those skin care and other oral hygiene and comfort measures, that creates an impression of neglect that actually feeds into a system of what I would call corrupt care.
Yeah. The next few years, the dials will all turn red across the health service with the financial situation we've got. Already we see numbers that nursing staff are being cut and that healthcare assistant numbers are going up. In that kind of situation, shouldn't the scrutiny from outside the organisations be stepped up? And if that is the case, what role does the RCN have in that, or indeed versus other possibilities such as the CQC, or indeed peer review systems to try to get some sunlight into what might be a kind of mass folly inside a particular organisation?
Well, I think it's going to need all the relevant bodies to actually take this very, very seriously. So it's not just the responsibility of the RCN, it's the responsibility of the individual nurses, of the trusts, of chief executives, of everyone in the system, the regulators and the professional associations and the unions.
Sure, but isn't there an issue there? I'm sure everyone here agrees. Isn't there an issue there that everybody but nobody is responsible? Isn't there a worry? I mean, I was very taken reading again at Midstaffs, the number of organisations that somehow knew something worrying was going on at Midstaffs, but nobody put it together. We had the data, we had the information outside the organisations. So it's almost as if there were far too many involved, but nobody thinking about it, nobody putting it all together, nobody orchestrating. So,
well, I think ultimately these issues, it's partly about data, and one of the, I think, the criticisms that's come out from Midstaffs, it's not necessarily the paucity of data, it's quite the opposite in a health system. I think we are assaulted by a tsunami of data. It's the intelligent interpretation of that, which has got to be coupled by taking a moral position on what do we believe the values are that this organisation stands for, and enacting those values in everything that we actually do day in, day out. And deviation from those values have to be checked. And the best way, I think, peer review, you mentioned, Jennifer, is that we need to be checking each other and our own behaviour. We're very influenced in our behaviour from fashion to what we actually eat in restaurants, to how we behave in the workplace, by what we see happening immediately around us. So if we can build quality and leadership into living those values in a systematic way, consistent way, I think that's the key word here, then that is something that actually has got to be, if you like, a revolution, we heard in the last talk, that actually comes from the heart as well as from the head and is enacted through the hands. So I think it's the sort of convergence of all of those things hitting that kind of harmonious sweet spot of hope as well as moral resolve for the future. And I think that's the kind of spirit that I've heard Robert discussing. It's that moral position. This cannot be allowed to happen again, and it takes a coalition of the willing and a huge collective effort to say enough is enough.
Okay, let's move on to Tim. Thank you. So Tim, the medics. I remember a long time ago now being on the wards, and you as a doc, you dealt with the medical stuff, you dealt with the drugs, you dealt with the procedures. You certainly didn't deal with the patients washing or the patients having the right clothing or whatever. There seems to be quite a lot of blindness written in the report, the blindness of the medics to what was going on. Not my job, someone else's. How are we going to get some kind of alliance really here between the docs and the nurses about the care in its entirety, not just medicine on one hand and the nursing stuff on the other?
I think there are two separate issues here, and I think the first is the one that we can all, I hope, buy into here. I mean, anyone here who's actually engaged in the delivery of healthcare, and I looked down the 139 names on the list and counted less than 10 that probably do actually deliver healthcare, should feel ashamed. Now, I think if they don't, that's a societal issue. And the first part of my answer to your question is there is a societal issue here, I think. There's an ethical, moral, whether it's children in schools or someone who's knocked over in the street and you don't stop, there's a societal issue. And I think all of us, I hope as human beings, should feel ashamed that this went on and would say, you know, that's actually a reflection of the society I live in, not the profession. It's a reflection on me as a human being. So I don't want to go into that, but I think Anne-Marie was just starting to get into that. And I think that's a major issue here. We should be ashamed, and we should be ashamed as a society. If we put that on one side, that huge issue, which we can start to enact and engage with now, then I think the crucial issue in what Robert has put forward, as far as I'm concerned, is leadership. Taking responsibility, saying, that is my responsibility. The entire well-being of this patient and the movement of the patient through the system in which they find themselves, whether it's in the community, in general practice, in the A&E department or in the hospital, I encounter them. It's my responsibility to move them on that journey, and again, within a framework of compassion and care as best I can. And there are hospitals in which that's achieved. I think one of the issues maybe we've got away from it, there are some successful hospitals. I'm not saying mine is, I'm not saying Jan's is, but there are undoubtedly successful hospitals here. And looking and comparing the culture and the systems that are within them, they're all subject to the same barrage of data, the same regulation, the same top-down control, but they get it right. And for me, the difference is the personalities and the leadership within those organisations and the teams and the systems that they've put in place. I work in intensive care. When I start on a Monday morning, it's me. And it's me for a week. And I'm responsible for every patient in there, whatever their disease is, and I'm expected to be in there 12 hours a day and some of the night, and I take responsibility for ensuring that the patients are cared for, along, of course, with my nursing and other colleagues. But it's my responsibility. I don't say I've done my bit, and now I'm walking away to see another patient, and I won't know whether that action has been enabled or not, because the next day it's me again, and the patient's still there, and the relatives are still there, and they expect me to do something about it. So I think, you know, a very brief answer, two issues. One, a societal, moral, ethical issue that I hope we can all engage with, must do, should do, can do, looking at the organisations that are successful, but saying, and the Future Hospital Commission, you would expect me to get a plug-in for that, of the Royal College of Physicians, which started 9 months ago, is crucially around this. Who is taking responsibility? Who is leading the team? Who is saying 24 hours a day, I take responsibility for that care, and we have to address that issue, and I think we can.
What's the practical main message from this for example, the clinical leadership coming from the college? What are the practical things that you think you can do as a result? I mean, I hear these words, I believe in them, but I'd like to know precisely what now is going to change.
The first thing is you say every bed in the hospital, 24 hours a day, has a trained doctor in charge of it. That's the first thing. The second thing is you say there is a chief of medicine, not a medical director. A medical director is taken up with revalidation, with compliance, with all sorts of systems, but an operational leading manager, a chief of medicine with a chief of nursing, inward looking, I'm afraid, yes, looking at the systems and taking responsibility on a 24/7 basis of ensuring that the patients within each of the wards are looked after and are managed, and that there is a responsible clinician in charge of them. And that may well involve a team of 7 or 8 clinicians, trained clinicians, taking that responsibility on and meeting twice a day and saying, how are the patients in your area, the acute medical area, the A&E department, the general medical wards, and so on and so forth. And it will involve a huge change in culture. I think we have become absolutely fixated, and actually as a family member, my mother and father were victims of this, of being fixated on primary angioplasty, getting the gastroscopy right. And there have been vast advances. We shouldn't in any sense criticise those. Stroke medicine has been transformed, but everybody sits and says, that's my target, that's the bit I'm going to concentrate on. And once I find out, Mr. Smith, you haven't had a stroke, I'm sorry, you're not my problem. And the absolute crucial change is saying, Mr. Smith, you haven't had a stroke, but I'm going to ensure, I will take responsibility for ensuring you have the care that you need and the investigation that you need for whatever it is you have got, and I will ensure that that occurs. So I think the whole, looking at the system as a whole, ensuring it comes under a single leadership structure that takes responsibility for the patient wherever they are in the hospital, so that relatives know who to go to. They can say the chief of medicine is in charge of this, and I'm afraid they will have to take the responsibility, but be rewarded with the status and, who knows, maybe terms and conditions that go with it. We need to get away from divorced leadership and get engaged with structured operational leadership and responsibility that goes with it.
Okay, thank you. Let's turn now to Jan, because Jan, you've been around a bit. You're now at GOS. But you've been turning around quite a lot of failing places. You've seen clinical failure, you've seen financial failure. You've just written a book called Too Good to Fail, which is out next month. Tell us a little bit more about your experience. Did any of it approach the mid-staff's proportions, dare I say?
No, I don't think it did. And reading your first report, Robert, was a shocking experience. As indeed, it's not the only shocking experience. I'd say reading the Maidstone report was a shocking experience. And I remember being told, because I thought I was going to be put into Maidstone and Tunbridge Wells, and I remember Candy Morris saying, read this, and she said, I think it's bad. And I thought she's probably exaggerating. When I read it, I thought, my God, you know, this is worse than anything I've ever come across. I do think, Robert, that this is an extreme end. And I think we can perhaps see why it is. It tells us things we need to know, and I hope many of us, when we read your first report, thought, my God, we've got to do something now, and certainly the reports before you wrote your first report. And one of the things I find, and I might like us all to reflect on, that there's a real retrospectoscope here. That very often we're anatomising what went wrong several years ago. And certainly I found that the first failing trust I got in, I was nearly sacked for the failings that were there before I arrived that I'd already done a great deal to put wrong. But unfortunately the statistics hadn't caught up with that. So I think that is a real problem. But in terms of the sort of things what one finds that relate to all this, I think there isn't a sense of unity and responsibility, and I think all your points about culture are right. I think they have to be drawn together, and I think culture has to be endogenous rather than exogenous. Although your recommendations, that's fine, unless that's drawn together, I don't think it will work. And I remember going into West Herts, very low morale, people doing their own things, no unity. And we got a very bad rating on the patient survey, the very good Pick a Patient survey, by the way, which is much better than the Family and Friends in my view, because it's much more comprehensive. And when you looked at that and deconstructed it, it gave a huge amount of insight in what we were failing to do. And so what I decided to do, we had to share that with staff. And we had mass meetings with all staff and said, what's wrong? Staff themselves were shocked. And we said, well, what are we going to do? Let's compose some values. And staff themselves did it. And they were on a single page. And because they'd composed them, they lived them. And I think that's more important than the NHS Constitution. I'm not saying we don't need to have national standards. I thoroughly agree with your views that we need a structure of explicit understood standards, and I also agree with your view that we need a professional inspectorate. And I think with CHI we had some professional people but no standards, and I'm afraid then, David, we moved to having standards but not having the professional people, and we need both. And if it were up to me, I would require people like us, require them to become inspectors for 2 or 3 years, leave their jobs, do it, and go back again, because that's the best way to get that. I think as a manager, I think you often feel like piggy in the middle. in all this. And what terrifies me, it does terrify me, is that I don't know what's going on. And so I think it's not just about requirements and duties, it's about total, not just transparency, but let me think of the word osmosis, diffusion, total soaking through of communication. And I've been saying that to my staff in Great Ormond Street, which communicates well, but not as systematically as it might. And what even in a great place like I'm finding, you talk to one or two parents' representatives on the members' council, I think they're quite difficult people, and you talk to them one-to-one, find out what's bugging them. Say, hey, there's something in this. We need to, and as soon as you share that with staff, they say, oh yes, we want to do something about that. So I think one of the things we always have to do is to say, our eyes and ears, are they there? What can we do? And be paranoid about that. I always say, communicate till people are bored with you communicating, rather than no one ever tells me anything. And the thing about, I will say something about telling the truth. I think that is quite a difficult thing, not just for the individual, which it is, but up the system, because people say, well, I told someone, and then no one did anything about it, so my duty's done. And very often it is not. And I think there is a problem if we push the obligation to tell the truth up the system. We can actually simply transfer an unreasonable pressure. And again, I can remember trying to be much more open in West Hertfordshire, and we started using the WHO checklist. And of course, we found in one or two cases that we hadn't got it quite right. So we started declaring one or two serious untoward incidents. And even just about on the rules, never events. So what happens? A big cosh comes down on us. You're an organisation full of never events. This great organisation, the person from whom was monitoring us, we never have a never event like that. You're obviously incompetent, and we'll sort of send the thought police in on you. 6 months later, we've been asked to explain what we'd done, and you know, the same august organisation discovered it was having rather more never events than we had. So there is this thing, do I want to be the first to be the truth teller? And I do worry in the climate that's being created, the first person who says we're getting it wrong, God, you must be awful. We will do something about you. And that is a pretty common experience I've had.